Good evening, friends. Welcome to the session. Good evening, all of you. I, Dr. Anuradha Dhawan, Ophthalmology Educator at Unacademy, welcome you to today's session, in which we will go through some syndromes in ophthalmology which are important for us to know. Okay, so I'll be beginning the session. Before beginning the session, let me just inform you that if you need any information beyond the class, you can either contact me on my email or through my Telegram group also, and of course through the Unacademy group at the Telegram. Okay, so let's go through the session. Important syndromes in ophthalmology. Okay, right. So let's first of all discuss about few syndromes with external eye abnormality. Okay, in which golden hair syndrome is a common one. Okay, so what are the features of golden hair syndrome which we need to know? Okay, so most important is your presence of colobomas. As you can see in this picture, there is an upper lid coloboma. So we can see a gap or a notch in the upper lid over here. This gap is called coloboma. Okay, now this lid coloboma is a feature of golden hair syndrome. Besides the lid coloboma, the patient can also have optic disc coloboma. Okay, another important feature of golden hair syndrome is your presence of dermoids, and especially the limbal dermoids, the dermoids at the position of limbus. Again, an important association with golden hair syndrome. The child can have strabismus, the squint. And what are the features of golden hair syndrome other than the eye features? So golden hair syndrome can be discussed as oculo-auriculovertebral disease. Okay, so it has features of eye, it has features related to ENT, and it has features related to the spinal system. Okay, nervous system and spinal system. So in the ears, there can be anoxia, preauricular tags, there can be facial asymmetry, and the child may have defects of skull and spine. Okay, so these are the association of golden hair syndrome which we must remember. After the golden hair syndrome, let's come to another syndrome which is important for us to know from exam point of view, which is your blepharophimosis epicanthus inversus syndrome. Okay, so this syndrome is short, we call it as BPES syndrome. Okay, so as the name is suggesting, now in this syndrome, two features are in the name of the syndrome itself: blepharophimosis epicanthus inversus. Okay, so there is blepharophimosis. Blepharophimosis means there is narrowing of the palpebral fissure. You can see the horizontal palpebral fissure is shortened, it is smaller. Then there is ptosis. We can see there is ptosis in both the eyes. Bilateral ptosis is there. The third important feature is presence of epicanthus inversus. What do we mean by epicanthus inversus? As you can see here, there is a skin fold from the lower lid to the upper lid. Okay, epicanthus is a skin fold from the upper lid to the lower lid. So when it is reverse of that, then that is known as epicanthus inversus, a fold from lower lid to upper lid. Then there is another feature known as telecanthus. So telecanthus is increased distance between the medial canthi of the two eye. We know this is the medial canthus. The distance between the medial canthi of the two eyes is increased than the normal. And last of all, there is an lateral ectropion of the lower lids. Lateral means the outer 1/3 of the lower lid has ectropion. So these are important features of BPES syndrome, blepharophimosis epicanthus inversus syndrome. Okay, just revising it once more. As the name is suggesting, there is blepharophimosis, that is shortening or narrowing of the palpebral fissure, horizontal palpebral fissure. There is ptosis, that is drooping of the eyelids. There is epicanthus inversus, a fold of skin from the lower lid to the upper lid. There is telecanthus, that is increased distance between increased distance between medial canthi of two eyes, okay, and lateral ectropion of the lower lids. Now this disease is an autosomal dominant disease. So if the parents they have it, so the children they'll have it, autosomal dominant disease. Okay, now the treatment in this disease we have to correct, because otherwise due to ptosis the child will have amblyopia. Okay, so first of all the correction of epicanthus inversus and telecanthus is done, and later on surgery for ptosis is done. Okay, this was about your BPES syndrome. Now let's discuss few syndromes with squint. Okay, or we can call as a special squints, out of which the most important one is your Dhawan's retraction syndrome. Dhawan's retraction syndrome. Now what is the basic pathology in Dhawan's retraction syndrome? That lateral rectus, which should be supplied by sixth nerve, which should get innervation by the sixth nerve, is not innervated by the sixth nerve, and there is aberrant innervation of lateral rectus by the third nerve. Okay, normally the sixth nerve supplies the lateral rectus, but in Dhawan's retraction syndrome, the sixth nerve is not supplying the lateral rectus. The third nerve is aberrantly supplying the lateral rectus. Now, Dhawan's retraction syndrome, there are three clinical types. Type 1, 2 and 3. Okay, so what are these three types? In type 1, there is limitation of abduction in the affected eye, that the eye cannot move out. Limitation of abduction in the affected eye. So if abduction is limited in the primary gaze, the eye will be in esotropia. The eye is in esotropia. Okay, in type 2, there is limitation in adduction, that is inward movement of the eye. There is limitation in adduction, and in the primary gaze the eye will be in exotropia. Okay, and the third clinical type is your, in which there is limitation of both abduction as well as adduction in the affected eye. Both abduction and adduction in the affected eye, and in primary gaze the eye is ortho, it is straight. Okay, out of these three types, the type 1 is the commonest one, in which there is limitation of abduction and the eye is in esotropia, as we are seeing in this. Okay, here left eye is the eye which is affected, and as you see here, right eye is straight and the left eye is having esotropia in the primary gaze. Another important feature, special feature of Dhawan's retraction syndrome is that when the patient moves the eye inwards, that is when the patient is attempting adduction, when the patient is moving the eye inwards, there is retraction of the globe and narrowing of the palpebral fissure, as you can see. So this is the normal palpebral fissure when the patient is in primary gaze. When the patient is trying to move the eye inwards, there is narrowing of the palpebral fissure and eyeball has retracted inside. Now this is because of, on adduction, there is contraction of the medial rectus which is supplied by the third nerve, but since there is aberrant supply of the lateral rectus also by the third nerve, there is co-contraction of medial rectus and lateral rectus in the same eye. So in the same eye, lateral rectus and medial rectus are contracting at the same time, due to which there is retraction of the globe. So this is a very unique characteristic which we see in case of Dhawan's retraction. So that is why it gets the name Dhawan's retraction syndrome. Okay, so the one which we are seeing here is your type 1 of Dhawan's retraction. The patient cannot abduct the eye. Abduction is not possible. On adduction, there is retraction of the globe. Okay, fortunately, many of these patients, they have got very mild degree of squint and they do not need surgery mostly. Okay, now moving on to few more interesting special squint cases. One is your Brown syndrome, or what is also known as superior oblique sheath syndrome. So we can imagine the abnormality is in the superior oblique muscle sheath or the tendon. Okay, right? So this syndrome is your Brown syndrome. So what happens because of this abnormality? that when the patient is looking up, that is elevation, when the patient is looking up, now in abduction, as in this picture, when the eye is looking up in abduction, that is out and up, that is normal, that is present. This is normal elevation in abduction. In this, superior rectus is your main elevator, so this part is normal. But when the patient wants to look up and in, that is elevation in adduction, up and in, that is limited. That is limited, as you are seeing in this picture. The patient, when tries to look upwards in adduction, that is limited due to abnormality of superior oblique sheath. Okay, so Brown syndrome, the causes, it can be congenital or acquired. Okay, so it can be present since birth, or it can be there due to the inflammation or fibrosis of the superior oblique muscle later on also. But this leads to this typical problem which is known as Brown syndrome. Okay, moving on to another type of special squint, that is your Mobius syndrome. The Mobius syndrome is characterized by bilateral sixth nerve palsy. Okay, so actually what is happening, there is congenital aplasia, that the nerve nuclei are not properly developed. There is aplasia, they are not developed. Which nerve nuclei? 6th, 7th, 9th, 10th. Okay, 6th, 7th, 9th, 10th nerve nuclei, they are not developed. So in the eye, it presents as bilateral sixth nerve palsy, as you can see in this child. Both the eyes are convergent because of bilateral sixth nerve palsy. Okay, due to seventh nerve palsy, there is facial palsy, bilateral facial palsy, which results in mask-like face. Okay, right? These patients, they mostly have mental retardation also. There is atrophy of the tongue, associated features. But for us to remember bilateral sixth nerve palsy due to congenital aplasia of the sixth nerve nucleus is your Mobius syndrome. Okay, fine. Moving on to certain syndromes which are associated with glaucoma. With glaucoma, that is increased intraocular pressure, in which first one we are going to discuss is your Posner-Schlossman syndrome. Okay, Posner-Schlossman syndrome, which is also given the name glucomatocyclitic crisis. So here the name itself is suggested what is happening. Cyclitic means inflammation of the ciliary body, okay, and trabecular meshwork. Glucomative means increased in intraocular pressure. Okay, so the clinical features of this syndrome, they are very characteristic. The patient, usually a young male, okay, the patient is usually a young male, presents with recurrent attacks of unilateral mild uveitis, that the cellular reactions, very few cells are there, okay, but very high intraocular pressure in the range of 50 to 40 or even 60 millimeter of mercury. So very high intraocular pressure, mild uveitis is there, and very characteristically there will be fine white KPs. Fine white KPs, they will be seen on the cornea. Okay, cells are very few, interior chamber cells are very few, but there are white KPs on the endothelium, and angles are open. So it is a secondary open angle glaucoma. So these are the typical features: unilateral, mild uveitis with few AC cells, fine white KPs are present, very high intraocular pressure with open angles. Okay, now what is happening here is the recurrent attacks and unilateral. So these things, they should point to the suspicion of Posner-Schlossman syndrome. The treatment is, because it is inflammatory in nature, the reason for the pressure is inflammation of ciliary body and trabecular meshwork. It is inflammatory in nature. We have to give topical steroids. And this is one glaucoma in which we are giving cycloplegic. Another one is your malignant glaucoma or aqueous misdirection glaucoma. So we'll be using cycloplegic to reduce the inflammation. We will give anti-glaucoma drugs to control the pressure. Many a time systemic anti-glaucoma is also required. And we will avoid miotics like pilocarpine. You are not supposed to give pilocarpine because pilocarpine increases inflammation. And we do not give prostaglandins for the same reason, because both of these, they increase the inflammation. So it is better to avoid miotic and prostaglandin in a case of Posner-Schlossman syndrome. So these are important points to be remembered about Posner-Schlossman syndrome or glucomatous-cyclitic crisis. Okay. Moving on to another syndrome with glaucoma, which is a congenital one, is your ICE syndrome. ICE stands for iridocorneal endothelial syndrome. ICE. Okay. So in this, the basic problem is that there is abnormality in the corneal endothelium, and this endothelium grows over the trabecular meshwork, the iris area, the angle structures, leading on to different abnormalities. Okay. So the basic problem is endothelial growth over angle structures and iris. Angle structure and iris. So there are three spectrums in ICE syndrome, which can again be remembered by the word ICE only. One is your presence of iris nevi. As you can see, diffuse iris nevi are present. So these are seen in Cogan-Rees syndrome. This is a part of ICE syndrome. There are three different clinical spectrums: iris nevi, Cogan-Rees syndrome. Then it can be Chandler syndrome. In Chandler syndrome, it is mainly the corneal endothelium which is affected, and we get an appearance of corneal endothelium which is known as hammer-beaten appearance of corneal endothelium. And the third spectrum is your essential iris atrophy or progressive iris atrophy. Okay, so these are all a spectrum of ICE syndrome. So these are associated with glaucoma also. You have to treat them accordingly. And important to remember, Cogan-Rees, iris nevi, Chandler syndrome, hammer-beaten corneal endothelium, and progressive iris atrophy is also one of the spectrum of ICE syndrome. Then another one to be remembered for regarding the glaucoma is your Sturge-Weber syndrome. Sturge-Weber is a sort of phacomatoses in which there are hemangiomas. Okay, so they are characterized by port wine stain hemangioma on the face. This is associated with ipsilateral glaucoma on the same side. As you see, there is a port wine stain on the left side of this patient, and there will be left glaucoma, ipsilateral glaucoma. If it is in the early age group since birth or early age group, it can lead to unilateral buphthalmos. This is also associated with episcleral hemangiomas on the same side, and there can be multiple leptomeningeal hemangiomas in the brain. So Sturge-Weber syndrome, important thing to remember, port wine stain and ipsilateral glaucoma on the same side of port wine stain. Okay. Then moving on to certain uveitic conditions which are associated with the syndromes. One important one is your Vogt-Koyanagi-Harada disease or Vogt-Koyanagi-Harada syndrome, in short known as VKH syndrome. VKH syndrome. Okay. VKH syndrome, HLA association to be remembered, it is DR4. This has spectrum of ocular features, neurological features, and cutaneous features. Okay, the ocular features, most important is your bilateral chronic granulomatous panuveitis, which is bilateral, which is granulomatous type. Okay, now this panuveitis, in the later stages, in the chronic stages, when there is degeneration of the RPE, leads to a typical appearance of the fundus. The fundus glow does not appear to be like a red reflex. It is your sunset glow fundus. Okay. In the skin sign, there is vitiligo, and there is also depigmentation seen in the limbal area. The perilimbal iris becomes hypopigmented, which is known as perilimbal vitiligo. and this sign is known as Segura sign. So Segura sign is associated with VKH syndrome. And in the neurological symptoms, the patient can have headache, patient can have tinnitus, patient can have meningitis-like features also. So this is your VKH syndrome, right? Then another important one are your white dot syndromes. Now, white dot syndromes include a spectrum of different clinical conditions, but in which the appearance, morphological appearance of the lesions is similar. And what do they appear like? They appear like multiple white dots, which are actually multifocal areas of chorioretinitis. So it's an inflammatory disease, and they appear as like these white dots, as you can see here. So that is why the name white dot syndrome has been given. So what all diseases, what all type of multifocal chorioretinitis can look like white dot syndrome? The commonest one is your APMP, in short what we call as APMP stands for acute posterior multifocal placoid pigment epitheliopathy. Okay. Then your birdshot chorioretinopathy, presumed oculohistoplasmosis, multiple evanescent white dot syndrome, in short known as MUDES, and serpiginous choroiditis. So these are the common choroiditis or chorioretinitis which appear in the form of white dots. Okay. Right. Now coming on to Horner syndrome. Now Horner syndrome, we know there is abnormality in the sympathetic innervation. The sympathetic innervation to the pupillary dilator muscle and to the Muller muscle. So that leads to the features which we see, ocular features in case of Horner syndrome. So there is problem in the sympathetic innervation. Sympathetic innervation to the Muller muscle, when it is affected, that is leading to mild ptosis due to Muller muscle palsy. So there is mild ptosis due to Muller muscle palsy. There is miosis, the pupil is smaller because the dilator pupillae is not acting. The dilator pupillae not acting, but the reaction of the pupil to the light and near are normal. Okay, this is important factor. Since the dilator pupil is not acting, so the Horner pupil cannot dilate in the dark. The patient goes to dark, the Horner pupil does not dilate. So that leads to increase in the different size of the two pupils in dark. What we call as anisocoria increases in the dark in case of Horner syndrome. There is apparent enophthalmos because there is mild ptosis. At the same time, the inferior tarsal muscle of the lower lid is also weak, which leads to apparent smaller, what she shall say, not smaller actually, the enophthalmosis, the eyeball appears to be more inwards. Okay. Then in the congenital cases or in the long-standing cases of Horner syndrome, on the affected size, the iris becomes lighter in color. The iris becomes lighter in color, which is known as heterochromia, hypochromic type of heterochromia, lighter in color. And if the lesion is before the cervical ganglion, then the patient will have reduced sweating on the same side of the lesion. So just quickly going through the features of Horner syndrome: mild ptosis, which is approximately just about 2 millimeter, miosis, smaller size of pupil, normal reaction to light and near, anisocoria increases in dark, there is apparent enophthalmos, and in long-standing cases there can be iris heterochromia and ipsilateral anhidrosis in preganglionic lesions. Okay. Then moving on to certain important neurological problems. If there are lesions at the level of superior orbital fissure, or at the level of orbital apex, or at the level of cavernous sinus. Okay. Now the lesions, the nerves which would be affected, of course, they depend upon which are associated with these areas. Now the nerves which are coming from the superior orbital fissure, there are your 3rd, 4th and 6th nerve and first division of the 5th nerve. So if there is inflammation in this area, the nerves which will be affected will be your 3rd, 4th, 6th and 1st division of the 5th nerve. Okay. But if the orbital apex is also involved, we know through the optic canal, optic nerve is passing. So then the optic nerve will also be affected. So orbital apex syndrome includes your 2nd nerve plus superior orbital fissure symptoms. Okay. But if the inflammation is in cavernous sinus, that is like cavernous sinus thrombosis, okay, then we know that optic nerve is not related to cavernous sinus. Okay, the nerves which are related are third, fourth, sixth, and first and second division of the fifth nerve. Third, fourth, and fifth are in the wall, and sixth nerve is within the sinus. So sixth nerve is the first nerve to be affected when the cavernous sinus thrombosis is happening. Okay. Now, what is Tolosa-Hunt syndrome? So this is a common term, common question which we come across, Tolosa-Hunt. So in Tolosa-Hunt syndrome, the involvement of the nerves which we just read, either presenting as a superior orbital fissure syndrome, or presenting as orbital apex syndrome, or presenting as cavernous sinus syndrome, can occur. But when it is idiopathic in nature, we do not know, we cannot trace the cause that why these syndromes are happening. So this can present as superior oblique fissure syndrome, or orbital apex syndrome, or cavernous sinus syndrome. Okay, either of these. But when the cause is idiopathic, then we will give it the name as Tolosa-Hunt syndrome. Okay, so am I clear about it? Okay. Then moving on to syndromes with the nerve palsies. So there is a table, of course, we'll have to remember it. So there are four syndromes which are associated with third nerve palsy, and 2 syndromes which are associated with sixth nerve palsy. Okay. With the third nerve is your Benedict. In third nerve, in Benedict syndrome, it is ipsilateral third nerve with contralateral flapping tremors. If this is the feature, then the lesion is at your red nucleus, when the third nerve fasciculus is passing at the red nucleus. In Weber syndrome, it is ipsilateral third nerve plus contralateral hemiplegia. Here the lesion is at cerebral peduncle level. In Northingel syndrome, ipsilateral third nerve with ataxia. Lesion, ataxia, think of cerebellum, so cerebellar peduncle. In Claude syndrome, there is combination of the symptoms of Benedict and Northingel, that is ipsilateral third nerve, tremors along with ataxia. Okay, so of course we'll have to remember it, but these are the 4 syndromes which are associated with third nerve. Then with the sixth nerve, Milliard-Gubler syndrome is the one in which sixth nerve is involved. Both sixth and seventh nerve are involved ipsilaterally, and contralateral hemiplegia is there. Here the lesion is involving the fasciculi of these nerves and pyramidal tract. Okay. Then there is your Gradenigo syndrome, which you read in ENT also, in which there is palsy of 5th, 6th, 7th and 8th nerve due to inflammation at the petrous apex. So please do remember this table to know that which nerves are involved in the given syndrome. Okay. And then last but not the least is your Wolfram syndrome. Now, Wolfram syndrome is also known as Didmod syndrome. Didmod. So, Didmod will tell you what are the features. Didmod stands for diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Okay. So, Didmod syndrome and Wolfram syndrome are same. The patient has features of diabetes insipidus, mellitus, bilateral optic atrophy, primary optic atrophy, and deafness. So these are the features. Again, it can be asked in your question. So we have put up this in the list. Okay. So that brings me to the end of the overview of the syndromes. Let's revise what we have learned with the help of MCQs. Okay. Coming to the first MCQ, a 40-year-old male patient complained of mild pain, mild blurred vision. Okay, with rainbows around the light, means history of colored halos is there. He gives history of similar attack in the past. On examination, there is minimal congestion, clear cornea, few cells in the interior chamber, and few fine charetic precipitates. The pressure is 46 millimeter mercury. Angle was open. Other eye examination is normal. So, see all the features. Attacks in the past, colored halos due to high pressure, okay, Minimal conjunctival congestion, few cells in the interior chamber, KPs are there, angle is open and other eye is normal. So it is a unilateral involvement. So what is the most probable diagnosis in this case? It cannot be acute angle closure glaucoma because angle is open. Pigmentary glaucoma again usually presents with the pigment deposition and not with the mild uveitis. So this is ruled out. If it is due to viral uveitis, the inflammation again is expected to be more. Whereas here we are dealing with very mild inflammation with high intraocular pressure, which fits into the clinical features of Posner-Schlossman syndrome. So this is a case of Posner-Schlossman syndrome. Okay. Now, ptosis in Horner syndrome is due to paralysis of Muller muscle, levator palpebral muscle, orbicularis oculi muscle, all of the above. Horner syndrome we know is the abnormality is in the sympathetic supply. Okay, and out of this, which muscle is supplied by the sympathetic supply is your Muller muscle. So ptosis in Muller muscle is mild because Muller muscle is a weak elevator of upper lid. Just about usually 2 millimeter ptosis is seen. Levator palpebral is supplied by third nerve. Orbicularis is supplied by seventh nerve. So right answer to this question is your Muller muscle. Which of the following is the true association? So few syndromes with their features have been given below. So we have to see which one is the true association. ICE syndrome with sunflower cataract. ICE syndrome is usually you have iris abnormality, you have corneal abnormality, you have glaucoma. The cataract, sunflower cataract is associated with Wilson's disease. So this is false. Golden-Hur syndrome with limbal dermoids is true. Sturge-Weber syndrome is not associated with telecanthus. It is associated with ipsilateral glaucoma and hemangioma, episcleral hemangioma. Down syndrome is not associated with ipsilateral glaucoma. So out of this, the true association is Golden-Hur syndrome. So we discussed limbal dermoid, lid coloboma, main features of ocular features of Golden-Hur syndrome. Okay. Then coming to next question, bilateral uveitis, skin depigmentation and tinnitus are feature of. So we are having ocular, we are having cutaneous and we are having neurological features. So remember this combination is seen in case of VKH syndrome. VKH syndrome presents with bilateral granulomatous uveitis, vitiligo, tinnitus, and even headache, meningitis like features they can be present. Okay. Posner has glaucoma, sarcoid is not associated with this, white dots are not associated with it. Okay. Then, which nerve palsy is seen in Weber's syndrome? So, in Weber's, we know it is the third nerve which is involved along with contralateral hemiplegia. Ipsilateral third nerve palsy with contralateral hemiplegia. So, right answer to this question is choice A, that is your third nerve. Okay. So, Wolfram syndrome is characterized by all. Wolfram syndrome is your, as I told you to remember, did mod. So it is your diabetes insipidus, which is true here, diabetes mellitus, which is true here, optic atrophy, which is true here. D stands for deafness. The thymic involvement is not seen. So this is, here we have to rule out the choice which is not a part of Wolfram syndrome. So that is your choice D. Okay. So with this, we end this session in which we have discussed important syndromes. I have tried to characterize it according to their features, that is associated with external eye features, syndrome associated with glaucoma, syndromes associated with squint, syndromes associated with uveitis, syndrome associated with neurological features. Okay. So many a times in the MCQs, in your entrance exams, they are there. So this is an important quick revision of these syndromes. Okay. So, one more question is there. Okay, let's do this. A 6-year-old child is brought by his parents with deviation of eye. So what is the diagnosis based upon the examination findings? Let's go through the examination finding. In the picture in the center, right eye is normal. Left eye is in EZO. The right eye adduction is normal. Left eye abduction is restricted. Okay. Right eye abduction is normal. On adduction, the left eye is showing retraction. It is showing retraction. So these are typical features of type 1 of Dhawan's retraction syndrome. Okay, limited abduction or adduction retraction. So whenever you see adduction leading to retraction of the globe, it's your Dhawan's retraction syndrome. Okay, so that is the right answer to this question. Okay, so that brings me to the end of today's session. I, Dr. Anuradha Dhawan, your ophthalmology educator, wish you all the best for your future endeavors. Have good learning, keep learning, and have put your best efforts to achieve your goals. Okay, so hope to see you soon in the next session. Okay, thank you very much.